My name is Brendan Reza. Today's date is 10/14/2024, and this is going to be the lung exam video. To start off the lung exam video, I'm going to test the blood pressure of my patient. The blood pressure cuff goes on the upper portion of the arm. It's going to be 1 inch or 2.5 centimeters above the cubital fossa, with the artery mark going directly over the brachial artery. The brachial artery can be found just medial to the biceps brachii tendon in the cubital fossa. I'm going to pretend like this is on the arm. My setup right now is a little flimsy. So that's over the arm, just how I described. I'm going to palpate the radial artery, and I'm going to pump up the blood pressure cuff to a point to where I feel the pulse in that radial artery go away. And I'm going to eventually record that value in my head of what that value is, because that could be my potential systolic pressure. When I go to check the blood pressure, I'm going to increase that pressure to that number plus 30 millimeters of mercury. I am then going to release it at 3 millimeters of mercury per second, and then record the first heart sound and record the last heart sound, and that will be my blood pressure. So let's go ahead and mimic that real quick. I have the diaphragm of the stethoscope over the brachial artery, and we'll say that when I did the radial artery, that was 100 millimeters of mercury. So I'm going to pump up to 130. 130, here we go. And I'm going to release it 3 millimeters. Goes down. First heart sound 100. Second heart sound 70. We'll say the blood pressure is 100/70. So the next thing that I'm going to do is I'm going to visually inspect the chest of the patient. Why I'm doing this is I'm going to be looking for breathing patterns. I'm going to be inspecting for rate, rhythm, and depth. One common abnormality that you can find for breathing rate is going to be from pleuritic chest pain, which is going to be tachypnea. Secondarily, you can also find or an abnormality for rhythm. That could be from post-stroke. Those are called Cheyne-Stokes breathing. You could also find an abnormality in the depth of the breath as well, and that could be from increased metabolic demand, also known as hyperpnea. Or that's not increased metabolic demand, but hyperpnea from increased metabolic demand. Next, I am going to ask my patient to shield, and I'm going to do a visual inspection of the chest, both anteriorly and posteriorly, looking at shape and symmetry. Two common abnormalities that you could find with this could be pectus excavatum, which is going to be an anterior concavity to the costal cartilages of the chest. That's most commonly associated. It is congenital, but most often associated with Marfan syndrome. Next, you could also find flail chest. That's going to be from an acute traumatic event to the chest that resulted in fractures of the ribs. Next, I am going to again ask my patient to shield, and I'm going to visually inspect the anterior and posterior portions of the chest. This time I'm going to be looking for masses, rashes, lesions, or scars. A common mass that you can find if the patient does have this pathology is going to be the left supracubicular lymph node or Virchow node. Whenever it's inflamed, that could be indicative of a metastatic gastrointestinal cancer. Another type of thing that you can find in terms of rashes could be shingles rash, which is caused by the herpes zoster virus. And that's the same virus that causes chickenpox, or you could find something like contact dermatitis from poison ivy or poison oak or something like that. So next with that, I'm going to visually inspect the neck. I'm going to be looking at the sternocleidomastoid muscles and the scalenes. I'm going to ask the patient to breathe normally. So as they're breathing normally, those muscles should not be engaged in that action. If they are, that could be indicative of labored breathing, and it could be an underlying pathology such as emphysema. So next, I'm going to go ahead and start palpating the patient. Again, the gown opens posteriorly, and I'm going to let the patient know that I'm going to palpate them on the back, and to let me know if there's any type of pain or hypersensitivity associated when I do that. So I'm going to go ahead and do it 4 times on the back. 1, 2, 3, and 4. My palms down. Again, I'm going to ask the patient to shield themselves, and I'm going to do the same thing on the front. It should be 1, 2, and 3. And if there's any pain, or if I can replicate the patient's pain while doing that, that could be indicative of a chest wall issue, not necessarily something from or a pathology from the underlying organs. Next, I'm going to do the exact same type of palpation, but this time I'm going to ask the patient to say the words 99, or the number 99, in a very deep voice. And what I'm looking for is fremitus, which is going to be some sort of vibration that could indicate some sort of lung pathology. So we're going to go ahead and do that. Say 99, 99, 99. Do the back as well. 99, 99, 99, 99. Again, this is the patient that should be saying the 99, not me. So next I'm going to go ahead and think about what I was going to do because I forgot for a second. Next I'm going to do the chest wall extension test. The chest wall extension test, I'm going to place my thumbs right around the area of T10, and I'm going to push in and towards the medial point, and I'm going to grab pretty firmly, and I'm going to ask the patient to breathe, take a deep breath in, and both my hands should both go up at the same rate and at the same time. If they don't, that could be some sort of unilateral lung pathology, could be atelectasis, I think is what you call it, atelectasis, or something else like that. Atelectasis. Man, that's a hard word. Anyways, so now with that, I'm going to go ahead and do some percussion. First percussion that I'm going to do is going to be listening for the long sounds of the percussion. What I'm looking for is a resonant sound. If I have hyperresonance, that could be a sign of emphysema, or if I have hyporesonance or dullness, that could be from something like pneumonia. So I'm going to go ahead and start at the front, and we're going to start at the apex. I'm going to go from left to right. 1, 2. Again, I'm asking my patient to chill during this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. I'm also going to do it in the back. There's 14 on this one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Okay. The next thing that I'm going to do is I'm also going to palpate for the level of the diaphragm. So I'm just going to ask the patient to breathe normally. And I'm going to go down to about the depth of T10. I'm also going to go a little bit above to where there's resonance in the lungs. And I'm going to tap down until I hear a dullness, which should be, like I said, about the level of T10. And I'm going to note that with a marker. I don't have it on me. I'm going to pretend my pinky is, and we're going to mark that with a wax marker. Next, I'm going to ask the patient to breathe in deeply, and I'm going to do the same thing. And that marker where I hear that dullness of the diaphragm should be lower than where it was when I first measured it. It should be about 3 centimeters. Next, I'm going to do the same thing where I have the patient breathe all the way out, and I'm going to do the percussion again. And that next marker where I hear that dullness of the diaphragm should be at the same level at T10 or slightly above. Again, that total measurement should be about 3 centimeters. And I will do that bilaterally, so let's go and do that here. There's one, mark it. Have them breathe in all the way, deep breath. Should be lower than that. Mark it, have them breathe out and hold. And it should be at the same level as T10 or a little bit above. Okay, next I'm going to auscultate for my patient, or it's not auscultate for, but I'm going to auscultate my patient. It's going to be in the same exact location, so I'm going to go ahead and ask my patient to shield again. What I'm going to be listening for is going to be for tubular sounds and or the vesicular sounds. The vesicular sounds are going to be right over the parenchyma of the lungs, and the tubular sounds are going to be over like the trachea and the bronchioles and stuff like that. 2 abnormal sounds that I could hear when doing the auscultation is going to be wheezing, which is going to be caused by constriction of those tubes, or could be crackling. Crackling is whenever you have fluid in your alveoli and you go to breathe in, those are going to expand and kind of pop open. And that's what you'll hear that cackling for. Let's go ahead and do this. I'm going to ask the patient to breathe in and out of their mouth every time. I'm going to also let them know to let me know if I'm going too fast. I don't want them to hyperventilate and start passing out on me. So here we go. Breathe in. Okay, I'm going to do the same thing in the back. Okay, and that is the end of the lung exam video.